Very good evening, all. Welcome to Isbar Connect, your source of reliable critical care information. So, today we are going to discuss one simple, important trial that is of very clinical relevance everywhere. So, this trial is Blink 3 trial. So, it is basically comparing continuous versus intermittent beta lactam infusions in ICU. So antibiotic infusion is one thing that we can easily do without much problem, without much requirement of additional equipment. So we're going to find out whether it is actually worth it and whether you need to follow it. So why you need to give an infusion of beta-lactam antibiotics? As we all know, beta-lactam antibiotics have time-dependent killing action. So the mean it means basically the longer exposure above the minimal inhibitory concentration of the antibiotic in the blood will improve the bacterial killing. So in sepsis and septic shocks, what happens is there is an increase in volume of distribution. There will be also increase in augmented renal clearance. And what happens is the drug level can reach below the minimum inhibitory concentration because of various factors like capillary leak state and consequent increase in volume of distribution, and there is also augmented renal clearance, especially in a young septic patients. So because of all these factors, you know and in additional factors, extracorporeal therapies, dialysis, CRRT, so there is a lot of antibiotic that is leaching out from the blood into the other compartments. So basically, these infusions help us to maintain a sustained level above the MIC so that we have good bacterial clearance. So that is the concept. So we are going to see in this trial, they have basically compared whether there is going to be any clinical translation of that concept. So previously there were two trials as well. It was the Mercy trial and the Blink 2 trial. So in the Mercy trial, they compared meropenem continuous infusion versus intermittent infusions. There was no mortality difference, and there was a Blink 2 trial back in 2015. In that also they compared beta lactams intermittent versus continuous infusions. Again, there was no mortality difference. So this is a truly national, international trial. Basically, we are having ICUs across Australia, New Zealand, and the Europe. So multi-center, multinational, open-label, randomized control trial. We had 7,200 critically ill patients, participate in this study across 104 ICUs across 7 countries. So truly an international trial, and the inclusion criteria was sepsis with one organ dysfunction as per the SOFA score, and any of these patients receiving beta-lactam antibiotics like piperacillin tazobactam or meropenem. So the criteria is the patient should be in the ICU with more than one organ dysfunction, and it should be ICU admission less than 24 hours. So exclusions include people on renal replacement therapy, pregnancy, allergy to any of the beta-lactam drugs. So what was the primary outcome? They compared the 90-day all-cause mortality between the continuous infusion group and the intermittent infusion group. So there was no much difference of all-cause mortality in the primary outcome, but they did an adjusted analysis. Okay, so there was some 2.2% or 0.89 with considered confidence interval of 0.79 to 0.99. P-value was 0.04. So there was some statistical significance. So anytime in a randomized control trial, in the primary analysis, if you're not getting any difference, they're also going for adjusted analysis. Means they're comparing patients with similar SOFA scores, similar Apache scores. Okay, so that is the adjusted analysis. But the main issue over here is you can talk about the secondary outcomes. In the secondary outcomes, the main issue you can see here is there is significantly higher clinical cure rate with a continuous infusion. So this is actually an advantage. Okay, so the issue is there is no difference in the primary outcome, which is all cause mortality, but there is a difference in secondary outcome, which is there is higher chances of clinical cure. There is higher chances of clinical cure. So the p-value is less than 0.001. So we have a significant p-value here, and the clinical cure rate is higher with continuous infusion. So it is clear. So there is no significant difference in the ICU hospital mortality rates, or side effects like Clostridium difficile infection, or side effects like any increased days on ventilator or renal replacement therapy, or renal replacement therapy, ventilator free days also, there is no much difference. But the clear cut thing that we need to understand is there is no increase in complications. So there is no increase in risk of Clostridium difficile infections or any other secondary infections. There were minimal adverse effects also. So the primary analysis of the 90-day mortality did not reach statistical significance. Okay, so continuous infusion significantly improved clinical cure rates. So this is the importance. The secondary outcome changed. Okay, and there is no evidence of harm associated with continuous infusions. So that is, you need to be very clear. There was no evidence of harm associated with continuous infusions. So what we can change in our practice, when possible, there is no harm in giving beta-lactam antibiotics as infusion. So that is the take-home point. So although we don't have change in mortality, we have one particular thing. There is increase in clinical cure rate, and infusing an antibiotic, it doesn't take anything much extra. You need an infusion pump. So they were comparing infusing the antibiotics, giving over 24 hours, the three doses. So each dose has an 8 hour or a 8 hour or 9 hour infusion. So conventionally they compared it with these bolus dosing that we give sometimes before. We used to give meropenem over 2 hours, over 1.5 hour, over 1 hour. So that is the intermittent dosing. So they compared this with a continuous infusion, which is for 8 hours. So if you have an infusion pump, you can start that, continuous infusions, and there are better cure rates. So why not follow it? And you don't need any much additional cost to the patient, and at the same time you can easily do it. So when you can easily do it, I think we should adopt continuous infusions. Thank you so much. Thank you so much for your time. We will meet in the next episode with a new trial which we can easily apply in our ICU. Thank you so much.